Ladies and gentlemen, thank you for joining the IMPRO's Colorectal Cancer Screening Conference Call. Your host, Melissa Ottinger, will begin.
Good afternoon, and welcome to today's webinar presented by IMPRO. This event is part of our Michigan Cancer Control Initiative, which aims to improve cancer screening rates throughout Michigan. If you would like to learn more, please visit cancercontrol.mpro.org. Today's event offers continuing education in the form of one nursing contact hour for registered nurses. Criteria for successful completion includes attendance at the entire event and submission of a completed evaluation form. The planners and faculty have declared no conflict of interest. IMPRO is an approved provider of continuing nursing education by the Ohio Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. I would like to introduce you to today's speaker. We have Mary Lou Searle, nurse specialist at the Michigan Department of Health and Human Services. Mary Lou works with the Michigan Public Health Institute in Comprehensive Cancer Control at MDHHS. She has focused on increasing colorectal cancer awareness and screening rates in Michigan for the past 7 years and currently serves as program manager for the Michigan Colorectal Cancer Early Detection Program. Before joining the Michigan Public Health Institute, Mary Lou had a variety of professional nursing experiences, including the development and oversight of community health promotion, screening, and early detection programs. Previous experience includes nursing leadership positions in critical care, medical surgical, cardiac rehab, and hospital nursing supervision. At this time, I would like to turn it over to Mary Lou.
Hi, thank you so much. And right now I'm seeing the slide with continuing education. Yeah, great. Could you advance that to today's objectives? Thanks so much for having me, and I just want to tell you that today what I'd like to do is help you identify clients at risk for colorectal cancer and really provide you resources to help you develop office policies and strategies and really a systematic way to increase colorectal cancer screening rates in your practices. Next slide, please. Next slide. Okay, simply put, colorectal cancer starts in the colon or the gut. I've used this slide just because it gives you a pretty good picture of the colon. So it begins on the patient's right side, extends across the abdomen, which is the transverse colon, down the left side of the abdomen, and also contains the rectum. So when we talk about colorectal cancer, we're talking about your large intestine and rectum. Next slide, please. Colorectal cancer is a slow-growing cancer, and usually it begins without symptoms in the early stages. That's why colorectal cancer screening is so important, because we know we can find colorectal cancer early in its most treatable stages, and even more importantly, we can find precancerous growth, remove them before they ever have a chance to turn into cancer. And most colorectal cancers begin as a polyp. If you look at the illustration on the right side, you're going to see the different stages of polyp growth where it changes into a precancerous growth and then into a cancer, which spreads to other organs, invades the lymphatic system, and gets into the blood system. So most colorectal cancer begins with a polyp, and that's important to know. Next slide, please. So, risk for colorectal cancer increases with age. If someone were to ask me, what's the most important risk factor? It's age. Turning 50 increases your risk for colorectal cancer, and I can't stress that enough. It's an equal opportunity cancer. It affects men and women. And if you have a personal or a family history of colorectal cancer or precancerous polyps, your risk for colorectal cancer increases. I'm also going to use the term CRC because sometimes it gets tiring saying colorectal cancer all the time. Next slide. In the state of Michigan, our current screening rate for colorectal cancer is 71%. So that means that 71% of the population, men and women over the age of 50, have been screened by a recommended screening method. Our goal is to increase nationwide the screening rate for colon cancer to 80% by 2018. And Michigan has taken that on. We've also worked with all of our partner statewide systems, health systems, primary care, American Cancer Society, the National Colorectal Roundtable. We all want to work together to increase those screening rates nationwide to 80%. So that's our goal. Next slide, please. The United States Preventive Services Task Force is a group of experts on colorectal cancer. And what they have done is look at the evidence for colorectal cancer screening, and they've established guidelines which say who should be screened, when they should be screened, and with what method they should be screened. And the task force, that group of experts, has recommended that men and women aged 50 to 75 should be screened for colorectal cancer. They also currently recommend against routine screening in adults older than 75 years of age. In addition to that, they stress that people with a personal or family history of colorectal cancer, they should be screened earlier than 50. Next slide, please. So how should you screen your clients for colorectal cancer? Well, the task force has said there are 3 different types of screening methods that are recommended, and they also recommend intervals with which you should provide those screening tests. So the task force says you should be screened by either an at-home stool test, a sigmoidoscopy, or a colonoscopy. And they're looking at adults that are average risk for colorectal cancer when they talk about all of these options. So they're saying that men and women age 50 who have no other risk factors could choose any of these options for screening. And the first group of tests look for blood that's hidden in the stool. That's abnormal. No one should have blood in their stool. And they recommend an at-home stool test. That must be completed every single year. And the 2 tests that are recommended for that yearly screening are an FOBT test and the FIT test. I'm going to talk to you a little bit more about those specific tests, and I'll give you more information, but I just want you to know that the first group is really at-home stool tests. An average risk client could choose to do that, or they could decide, you know what, I want to complete a test every 5 years. I don't want to be doing something every year. They could choose to complete a sigmoidoscopy. And that's a test that actually looks inside the colon. The physician is going to be looking at the left side of the colon. It's not going to be the entire colon. It's going to be the sigmoid area, into the ascending colon, maybe into the splenic flexure. They also recommend that with that sigmoidoscopy, you should complete a FIT or an FOBT at year 3. A client could decide, you know what, I don't want to do those 2 tests, but I want to complete a colonoscopy. If the client wants to complete a colonoscopy, as long as it's normal, you only have to complete that test every 10 years. And a colonoscopy does look at the entire colon. So there are advantages and disadvantages to every one of those tests, and I'm going to review that a little bit right now. Next slide, please. Oh, could you flip to the next one? I want to flip back and forth on these. So just to remind you that an average risk client is a man or woman who's 50 to 75. They have no other risk factors for colon cancer. They have no symptoms for colon cancer. So that average risk client could be screened for colorectal cancer by any of those options that we just talked about. And that's 85% of the population is at average risk. So 85% of your patients could choose to have any of those recommended screening tests. It's also important to note that the task force, that United States Preventive Services Task Force, says that in head-to-head comparative trials, there is a lack of evidence that any one of those tests has a greater net benefit than the other, as long as the patient completes that screening at the interval that they recommend. So that's really important to know, because your patient's preference and local availability of the test really plays into what is the best screening test for your patient. Next slide, please. So the first group, those at-home stool tests, I want to compare those tests a little bit. There's actually been more research on the FOBT test, the fecal occult blood test, than any other colorectal screening method. Both of these at-home stool tests are recommended, and they're economical compared to any other screening test. Now, why might you choose an FOBT over the FIT or the FIT over the FOBT? What I can tell you is that the FOBT, while it's very economical, you have to complete multiple samples of stool. You have to obtain multiple sample stool specimens. With a FIT, you might just have one stool specimen that you're taking a little tiny dab and swabbing it on a card. With a FIT, there's also no dietary restrictions or medication restrictions. So sometimes the FIT test is a little bit easier to complete than the FOBT because there's less things that really come into play with what the patient has to do or restrictions for the patient. Both tests still must be completed annually. And if one of those tests, if they choose to do a FIT test, if it's positive, or if an FOBT, one sample of that 3-sample test is positive, the patient must have a colonoscopy. So it's important to know that there are advantages and disadvantages to the FOBT and the FIT. I'd say that as far as risk, there really is no risk or harm for this particular test. The risk comes if the patient has a positive test and they have to have a colonoscopy, because a colonoscopy does come with some inherent risks. Next slide, please. So reasons to use an FOBT or the FIT is economical, research recommended. Some of your patients can't really have a colonoscopy. Maybe the patient doesn't like the idea of a colonoscopy at all. It's not appealing. The actual test itself and the idea of a prep isn't something they want to do. Maybe they don't have time off work. They don't have a driver to get them to the colonoscopy. They might have some financial concerns. Even if they have insurance, maybe it doesn't completely cover a colonoscopy, so an at-home test is a really good option for them. And sometimes, in the Lansing area, there's really not a problem with getting to a provider for a colonoscopy, but in some of the rural areas of the state, and certainly in the UP, access to a colonoscopy and a provider that completes colonoscopy is a huge issue. So there's various reasons why a person might want to complete an at-home stool test for their screening. Next slide, please. I wanted to put this slide on that shows you just a picture of the high sensitivity FOBT kit that is recommended for colorectal cancer screening. Right now, the task force has said that a high sensitivity test must be used for an FOBT. So it should say the word SENSA on the kit, or high sensitivity. And to my knowledge, the only kit that is available that says SENSA is this Hemocult SENSA by Beckman Coulter. So if you're completing FOBT tests for your patients, it has to be a multiple sample test, it has to be completed at home, and it has to say the word SENSA or high sensitivity in it for it to be an effective recommended test that the patient completes annually. Next slide, please. Now the FIT test, there are many FIT tests on the market, and as recently as November of this past year, November of 2015, the task force said that of the FIT tests that have been cleared by the FDA, the test with the best test performance is the OC Lite test and the OC Fit Check test from Polymedco. They have the highest sensitivity and highest specificity of any FIT test on the market. Now, they're not just recommending that one, but they're saying that they're letting everyone know that this test has high sensitivity and high specificity. And what that means is that When a patient has a positive, it's really a positive, 90% of the time, 99% of the time. I don't remember the exact numbers. And they're also saying that when it's negative, you can really trust that it's negative. That's what specificity is. Next slide, please. This is important to note, and I'm going to tell you I'm going to give you an example of this. Colorectal cancer screening by a FIT test or an FOBT must be completed at home. Collecting an in-office stool on the tip of a finger is not an acceptable colorectal cancer screening method. And the reason is because it can miss 90% of advanced neoplasms. So I can honestly tell you that I'm not worried about the patient, that if a physician did that, swiped their glove on a Immunochemical card or on the FIT swab and it came up positive, I wouldn't be worried about that. That patient's going to go for a colonoscopy. I'm worried about the ones that are negative because I don't know for sure if they're really negative because it is not a good stool sample. So I want to tell you that regardless of what the representatives from the company say for any FIT test or these cannot be completed in the office. That is not the right way to increase your colorectal cancer screening rates and increase compliance. And I want to let you know that you can follow up with me with any questions about this because I've worked with a lot of offices to change some of their practices. Next slide, please. Of course, I always get asked, so what, do you have a list of things that aren't recommended? And what I can tell you, and this is an ACS list, actually, and it says that the Immunochemical slide, all of these kits are no longer recommended. So if you want to refer back to a list and check in your cupboards, definitely these are not recommended. This is not the whole list. I'm sure there's other kits that aren't recommended, but at least I can give you this. Next slide, please. So that second group of tests for colorectal cancer screening includes tests that look inside the colon. Next slide, please. Any client who is at increased risk or high risk for colorectal cancer must have a colonoscopy. They do not have options for colorectal cancer screening. So the clients at increased risk for colorectal cancer are those that have that personal history or a family history of colorectal cancer or precancerous polyps. So that means the patient either had a scope before and they found that they had precancerous polyps and they were removed, and now they need to follow up with a colonoscopy again, or maybe their mother, their father, their sister, their brother had either colorectal cancer or they had precancerous polyps. That puts that client at increased risk for colorectal cancer, and they need to be screened by a colonoscopy. Of course, there are people that are really outside of, there's a small group of patients that are going to be high risk. Those are the clients that come to you and they're having symptoms. They're having blood in their stool, they've had bowel changes, and even though I told most patients won't have symptoms with colorectal cancer in the early stages, they will develop symptoms later. So if a patient has symptoms that are high risk, they need a colonoscopy. And of course, there are other genetic syndromes, ulcerative colitis, Crohn's disease, that put people at high risk and they need to have a colonoscopy. They are not able to do any at-home stool testing for colorectal cancer screening. Next slide, please. This is a photo of a colonoscope. A sigmoidoscope that's used is really going to be, it's going to look pretty much the same. It's just going to be a little bit shorter. But basically, the gastroenterologist or it could be a nurse practitioner, could be a physician, depending on a surgeon, someone trained to do colonoscopies, would be looking on the end of that scope. They would be sliding wires down to take out any polyps that they might find, and of course there's a camera on the end of it so that they can see inside the colon. Next slide, please. So a sigmoidoscopy, the physician is going to use a sigmoid scope. They are going to go into the area of the sigmoid colon. So they're going to look in the rectum for polyps or for any abnormalities, and they will be looking, sometimes they can get as far as the descending colon into that flank flexure, but you're going to notice they're not going to be able to see the entire colon. So the area that's green, purple, and yellow, the rest of the colon down to the cecum, they are not going to be able to see during a sigmoidoscopy. But remember, the task force has said that completing a sigmoidoscopy is a recommended screening every 5 years, as long as you're doing it with a FIT test too, on the 3rd year. And the rationale behind that is that a lot of polyps are in the rectal area and the descending sigmoid colon area. They feel that a FIT test done at intermittent levels is going to pick up any intermittent bleeding from a polyp. So if a polyp becomes abnormal and it's having some bleeding intermittently, that should be picked up with that FIT test that's done in between that 5-year interval on the sigmoidoscopy. Next slide, please. So a colonoscopy is the procedure where you're looking at the entire colon. You're looking from the rectum to the cecum. So the physician needs to get to the cecum, and they need to identify the appendiceal orifice. They need to identify that they see the terminal ileum, and they really need to look at all the folds in the cecum. And they're looking for polyps that I talked about earlier. Some of the polyps are going to be mushroom-shaped. That's called pedunculated, or they're going to be sessile, which are flat ones. And if you go to the next slide, one of my GI friends shared this slide with me, and you can see on the bottom, in the middle, there's a nice mushroom-like polyp. That kind of a polyp is easy to see, it's easy to lasso, and basically excise and then send that polyp to pathology to find out, is it precancerous, is it benign, and what our next screening interval should be. But if you look on the slide on the bottom left, that's a sessile polyp. It's still a polyp, but it's really flat. It's grown into the colon, so the physician really needs to have a good bowel prep to be able to see those, and they need to do a wider excision of that polyp to make sure that they got all the area around the polyp, and when they send it down for pathology. Next slide, please. And here's a couple pictures of colorectal cancer, and you can see that this doesn't happen. This happens over time. This is when somebody usually when someone has not been in for screening. Of course, it could be somebody that's at higher risk for colorectal cancer, but, it's just nasty stuff, and it's one of those things, again, that we know we can prevent with routine screening. Next slide, please. So what are the potential harms with those more invasive procedures? The primary risk for colorectal cancer screening comes with a colonoscopy, and I want to add the sigmoidoscopy too. But specifically with the colonoscopy, the patient has to have a prep, so they can have dehydration, there could be electrolyte imbalance, they could develop an infection after the excision of a polyp, they could have some bleeding after the excision of a polyp, there could be perforation of the colon. During the procedure, they receive sedation. There could be some events, cardiovascular events, or they could have a response to the sedation during a colonoscopy. As far as a sigmoidoscopy, there could be a perforation, there could be an infection. So these procedures are much more invasive than your at-home stool testing. They do come with some risk. Although some people will say that it's a small risk, it's still about 1% to 2%, but I want you to remember that there are risks with these particular colorectal cancer screening methods. And age, of course, always increased risk. That's why it's really important to make sure that when you're talking to patients, do they have other comorbidities? What's the best screening method for them? Are they healthy enough to get through this screening? And then again, if you screen them, are they healthy enough for treatment? So you really need to look at all the potential harms and risks and the pros of every screening method. Next slide, please. So currently, providers recommend, for the most part, colonoscopies. They think that if you ask providers what's the most effective screening method, they're going to say a colonoscopy. 25% think that a FIT's effective, and only 10% think that an FOBT is effective. Now remember that task force has said that all of these are effective, recommended screening as long as they're done at the correct interval and with the appropriate risk client. So average risk clients have choices. A colonoscopy is still the preferred method with most providers. Most providers will say, you should be screened for colorectal cancer, go get a colonoscopy. That usually is said even though scopes might not be readily available, and even if it's a financial burden to a client. I'm going to tell you really briefly about a conversation with a provider that we worked with who is serving underserved clients in a clinic. And one of the things he said to me is, we just recommend colonoscopies to everyone because that's the gold standard. And I really want to get away from that gold standard. So when he said that, I said, that's great. I'd love to offer colonoscopies to everyone. But you know what? Patients can't always afford that. And most of your population is probably uninsured or underinsured. And he said, yeah. And I said, well, what's your screening rates for scopes? He said, well, it's really good. Well, the nurse that does the QI said, well, we're at about 30%. And he was surprised by that. So in the end, after working with them for over a year, the providers and the residents started to offer options for screening for average risk clients. And what they found, and I told the nurse I was working with, I said, let the numbers talk. What they found that was they had an 80% completion rate with the FIT kits that they were using. And they still had about a 32% screening rate with the colonoscopies. So all of a sudden, the numbers talked to the provider, and he said basically, you know what, this is really good to start offering these people options because it really does work. And I didn't think they'd complete that at-home test, but with our patient navigation that we're using, they really did complete the test. So it's a good thing to remember that options for average risk clients are very, very important. Next slide, please. This just reinforces considering patient preferences is really important. And this is actually a study that they did. There were about 1,000 average risk men and women at a clinic. This was an urban clinic. And basically they wanted to find out that if they made recommendations for screening, how many people would complete that colorectal cancer screening within 12 months of the recommendation. So for part of the group, they recommended FOBT. Part of the group, they recommended getting a scope. And part of the group, they gave them an option. And what they found that out of that 997 men and women, 58% completed the screening test. But surprisingly, of the clients that were offered a colonoscopy, only 38% completed this. The people who were offered just an FOBT, 67% completed that. But if they were given a choice, 69% completed the test. So again, options are important. Race did play into it a little bit. They did find that the white population with that particular group tended to complete colonoscopies more than the black population. And the African Americans completed an FOBT, the at-home test, more frequently than the Caucasians did. So there was a lot of information that came from that particular study, but I like to show it that, options do make a difference. Next slide, please. I briefly want to tell you about emergent science, and this is important because the task force has made a draft recommendation in October of last year. These are not current guidelines. They are recommendations. It's a draft right now, and we're waiting for the new recommendations to come out. Next slide, please. And the recommendations for colorectal cancer screening, the draft recommendations in November are very similar. So the task force is still saying screen people 50 to 75 years of age. But what they're saying, too, is they're not recommending against screening of that 75 to 85-year-old group. They're saying look at them as an individual, look at their prior screening history. If they haven't been screened for colorectal cancer, they're the ones most likely to benefit. So they're saying be cautious about doing this. they're giving a grade C rating, and that's a little bit different. So they're not recommending totally against screening of that 75 plus group, but they're saying really look at the individual. Next slide, please. The other thing that they've changed is that in the draft, I want to stress draft recommendation, they're still saying a FIT or high sensitivity FOBT every year. They're still saying colonoscopy is an option for clients every 10 years at their average risk. But now they're saying that if you complete a flexible sigmoidoscopy, it could be done every 10 years, not 5. But they want a FIT test to be done every year. So there's a little bit of a change. I don't know when they're going to make a decision to either say that this are the new screening guidelines or if they're going to go back to the drawing board, but these are the draft recommendations for colorectal cancer screening, and you may be seeing something in the press fairly soon about an update on that. Next slide, please. And I know Canada doesn't really have, it's not the United States, but I want you to know that Canada, as recently as February 22nd of this year, came out with their guidelines, which are based on evidence for colorectal cancer screening, and they actually are recommending not using a colonoscopy as a screening test for men and women aged 50 to 74. And they're saying that because they don't feel that there's evidence that that is the most appropriate screening test for that average risk client. They're saying basically adults 50 to 59, and especially that group 60 to 64, should be screened with either a FIT every 2 years or a sigmoidoscopy every 10 years. I'm talking about this specifically because I want you to know that in other countries, they use sigmoidoscopy and they use at-home stool testing much more than we do in the United States. And Canada has taken it kind of to a new level with their draft recommendations for colorectal cancer screening. So this is just a brief synopsis of a lot of information about screening recommendations. But it reinforces that options are a good choice for clients who are at average risk for screening. Basically, they're 50 years of age to 75 years of age, and they have no other risk factors for colorectal cancer. Next slide, please. So what do you do to increase colorectal cancer screening, and how do you do it? We support patient navigation, and patient navigation really is a process that you use working with your clients. You're assisting them through outreach to the completion of screening and treatment, and you're identifying individual barriers for screening. And so you're helping the client to get screened, and you're using strategies that are known to be effective to increase screening rates. And those strategies are found in the community guide, which I'm going to show you in the next slide. And they're focused on client-oriented interventions and provider-oriented interventions. So you don't have to sit at your desk and think, what can we do to increase screening? We know through research what kinds of activities increase screening. Next slide. So the task force, that group of experts, has said that there are different kinds of interventions that work for colorectal cancer. And if you look on the far right, you're going to see green kind of ovals for colorectal cancer. And the interventions that work that are focused on the client are client reminders, small media, one-on-one education, and the reduction of structural barriers. And succinctly put, structural barriers are barriers to screening that aren't financial. The other kinds of interventions are things that the provider can do. And that provider assessment and feedback, which is know your numbers for colorectal cancer screening. And the other one is provider reminders and recall systems. And I'm going to go into all of these in the next few slides. Next slide, please. So client-oriented strategies, next slide, focuses on one-to-one discussion with the client. You really need to discuss personal and family history. You've got to find out about their risk. You've got to help the client understand what is the benefit to them, because if they don't feel there's a benefit to colorectal cancer screening, they're not going to be completing screening. Discussing options and preferences, reducing any barriers, and most importantly, assess them for readiness to screen. I always ask a client, all right, so we've talked about this FIT test. You said that's the one that you want to complete, or you want to complete a colonoscopy. What's the chance of you walking out of here and actually doing it? And most of the time, clients will tell you yes or no. I mean, they'll actually tell you. So ask them if they plan to complete that screening test when you're talking to them. The conversation with the provider is the most important factor in getting people screened, because that is really what starts screening and what patients are the reason that they actually got screened. Next slide, please. Talking points. You only have a short time to talk to clients, so make sure that you've got a few talking points. And I would really focus on age. Let them know that they don't have to have symptoms in order to have colorectal cancer. So we want to catch it early if they have colorectal cancer, where it's most treatable, and that there's options for screening. So some of these talking points are very effective in talking to clients. Limit your jargon, assess their readiness. If they're not quite ready, make sure you talk to them about, hey, we can talk to you in another three months. Is that okay if we get back to you? Next slide, please. Best screening option. The best screening option is going to be the one that's risk appropriate and gets done. So assess your client for risk, talk to them about preferences, and readiness to screen. These are some of the barriers to screening. Sometimes clients don't know what colorectal cancer screening is. They don't know what an at-home stool test is. They might not know what the word stool is, so use words that they understand. Use poop. Use, poop on a stick. You're going to take a little bit of a sample, and you're going to put it on a card, and it's going to go in the mail. Talk to them so that they understand this. Sometimes there's an ick factor, whether it's that at-home stool test or a colonoscopy. Patients might not want a colonoscopy because there's fear of the colonoscopy. They don't like the idea of the prep. They don't like the idea of a tube, whatever it happens to be. And financial is a huge issue. There are cultural barriers. There are some cultures where it's very private. The females are covered up. The thought of having a colonoscopy is something that is very difficult for them to accept. So you really have to work with clients, and you have to gain their trust and their support in order to get colorectal cancer screening done. So you need to assess all those barriers. You need to talk to your client about the barriers, and you need to help overcome the barrier and find the best screening option. Next slide, please. We use small media a lot. Client reminders. It's a recommended strategy for colorectal cancer screening to increase it. And I'm sure you've seen a lot of information from the American Cancer Society. They have a lot of brochures. They have flyers. They have postcards to use to increase colorectal cancer screening. But what I can tell you is that there's another really great site. It's called Make It Your Own. And you're going to see links throughout this presentation where you can just click on the link, and it's going to take you directly to the site of the resource. This is going to take you directly to a link where you can make your own postcards or printed materials. You can make letters, postcards, brochures. You pick out your picture that you want to use that represents your clients. You pick out the message that you want to use about colorectal cancer. They have all kinds of messaging that talks about colorectal cancer screening. Some of it's based on, you've turned 50, it's time for screening, or maybe it's humorous, maybe it's religious, maybe it's spiritual. They're all research-based, tested messages. This was developed through WashU at St. Louis and the CDC. We use this site a lot for colorectal cancer screening. And if you look at the next slide, you'll see some of the examples that were created. And there's a lot cooler, better ones, but this gives you an idea that sometimes you might want to send out 50th birthday reminders. It's like, tell people it's time to get screened. And again, you can pick up any photo that you want, any message that you want, and there's hundreds of messages. The next slide shows you an example of approaching it from you want to do it for your family because your family cares for you. Get screened early, stay around, live life. Don't die from colorectal cancer. So this is an example of one of those slides. You can put your own logos on it. You can put your own office numbers, contact information. Depending on what you put on this slide, you can set it as a postcard, or if there's some specific information related to that patient that might be confidential, you're going to want to put the postcard inside an envelope. Next slide, please. All of the slides translate into Spanish, so if you have a Spanish population, you can create a slide like this. We actually had some rural areas in Michigan that were really targeting men, and they were targeting farmers. So they had a man that was on a tractor, had a message about getting screened for colorectal cancer, and it was really cool because they took it to grain elevators, and they took it to where the farmers gathered for coffee in the morning, for their coffee clutch, and the men and women were in there. So VO does have messaging which is very specific about your population, and it's worth a look. The next slide is something that you could use for office information, and I like to say that the entire office is involved in colorectal cancer screening. So the receptionist, whoever is at the desk, an MA, an RN, receptionist, could say, hey, I see you're 50. We're going to talk to you about colorectal cancer. There's some information over in the waiting room. Take a look at that, and then there might be some questions you want to ask your doctor about colorectal cancer, and it kind of gives them an outline of what the doc might be talking to them about and what the nurse might be saying about colorectal cancer. It gives them a little prep ahead of time. Next slide. So client-oriented strategies include those email reminders, putting a return address on a FIT kit. So if you're giving FIT kits out, put a return address label for the lab. So once the specimen is collected, it goes directly to the lab. There's no barrier to getting that mailed. Some people will put their postage on the FIT kits so that there's no problem with a client, getting a stamp. It's important that you track all of the kits that go out, track your colonoscopies that are scheduled, make sure that the screenings are completed. If they're not, call the client to see what you can do to get that screening done. Find out what the barrier is. If a client's having a colonoscopy, you might want to call them a couple days ahead of time and say, hey, do you have your liquids for your bowel prep? Make sure that you're hydrated, because if you're not, your prep is not going to be effective. So lots of ways that you can approach client-oriented strategies to increase screening. Next slide, please. Next slide, please. Reducing structural barriers is important, and all of these bullets really are barriers to screening. And with a little bit of your help and patient navigation, it increases colorectal cancer screening. Translation is very important. Transportation can be important. Sometimes just finding out what resources are in your community and might be available to help your client is a great way to reduce structural barriers. Next slide. Provider-oriented strategies for colorectal cancer screening from the community guide are provider assessment and feedback. Your physicians need to know, and your office staff needs to know, their current colorectal cancer screening rate. Because if you ask most physicians what the rates are, they say, hey, we're doing great, when in fact their rates are fairly low. And it's a surprise to them. So, people are competitive. They're competitive with themselves. They need to know, if I do something to increase colorectal cancer screening rate, does it make a difference? So if I implemented patient reminders in January, did I actually increase colorectal cancer screening rates by the next December or in June? So it's important to know those screening rates. And provider reminder and recall systems have to do with identifying clients that are in need of screening, flagging your charts. Some people use, like a red index card, and they put it on the chart so it reminds the office staff that, hey, this patient's 50, we should talk to them about screening, they're due for screening, and then the nurse talks to them, the receptionist might even bring it up, and then the physician really makes sure that they know about their options for screening and get settled on what screening method is best for them. Next slide, please. Developing an office policy is important for screening. And, I hate the word policy. What it really is develop a process. Decide what you're going to do as a team, and then have everybody involved in colorectal cancer screening. get everybody knowledgeable about colorectal cancer screening because it begins at your front desk. Every staff member is important to this. We need to make sure that providers are on board, that you've got a champion in the office, and that you really develop that team and you train the team to talk about CRC while the clients wait, to assess your eligibility, have some talking points, and that you follow up with all colorectal cancer screening to make sure that it's completed. So these are, this is a lot of information about colorectal cancer screening, risk, methods, and developing a team approach to colorectal cancer screening, but it's so important to move that screening rate. If you want to increase colorectal cancer screening rates, it starts in the office and it starts with you. And next slide, please. So start the conversation. Hearing from you, from your physician, is the most important in increasing those screening rates because the patients trust you and it makes a difference in their life. And after this, you're going to see a number of resources for screening, for risk assessment. I know I provided some one-pagers. They were attachments which has an example of, like, what is average risk? And it's a little algorithm, or what is increased risk? And it's an algorithm, a one-pager from the American Cancer Society manual, one of the toolkits for colorectal cancer screening. So be sure and take a look at some of the resources that I've shared. And I'm sorry we started a little late, but if there are any questions, I'm open to questions about colorectal cancer screening, and I'm open to any calls or emails after this, too, about how to increase your rate.
Mary Lou, thank you very much. This is Melissa, and I just wanted to let everyone know that when we send out the slides to the registered participants, we'll also be sending out those two documents that you just discussed.
Great.
And then, Katina, do you want to open the lines for questions?
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, ladies and gentlemen, if you have any questions at this time, please press the number 1 key. There are no callers in queue at this time.
Okay, we can wait another minute or so, but in the meantime, I wanted to thank everyone for joining us today to discuss colorectal cancer screening. Just a reminder that the slides and the documents will be sent out to everyone who is registered. Also, a full recording of this webinar will be available on our YouTube page within the next week. If you're seeking continuing education credit, please visit education.mpro.org to fill out the evaluation. And if you have any questions about that, please contact Katie Brown at kbrown@mpro.org. Some of our upcoming webinars include Meaningful Use 2016 Challenges and Changes on March 16th, Vaccinating the Immunocompromised on March 24th, and Billing for Tobacco Cessation on May 10th. Katina, if you could check the line again for questions.
Again, ladies and gentlemen, if you have any questions, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. Melissa, there's no questions in queue at this time.
Okay. Then, Mary Lou, if you have nothing else to add, then I think we are all set for today. I want to thank you again for joining us and for this excellent information.
You're very welcome, and again, if anyone has questions that they want to ask later, or you have questions about resources, anything at all, just be sure and contact me. The information's there and available, and we are here to do everything we can to help increase colorectal cancer screening rates in Michigan.
Thank you. Katina, this concludes our call.
Thank you.
Ladies and gentlemen, this concludes your conference call. You may all disconnect, and I hope you have a wonderful day.